Hello students, I am Dr. Amit Kumar Adya, and in this video lecture I shall be talking about testicular tumors. Let us recapitulate the normal histology of testis. The testis is composed of numerous seminiferous tubules which are bounded by a basement membrane. Within these tubules, the germ cells are present in various stages of their maturation. The germ cells are supported by cells known as Sertoli cells, which are usually present at the base of the tubule. In between these tubules, the empty space that you see is known as the interstitium. Within the interstitium lie clusters of Leydig cells. The Leydig cells are responsible for production of testosterone. A tumor in the testis may arise from any of these cells. This is the classification of the tumors of the testis. In fact, lymphomas, metastatic carcinomas can also occur in the testis, but most common tumors that you encounter in testis are derived from the germ cells or the stromal or Leydig cells. So we will focus our discussion on the germ cell tumors and the sex cord stromal tumors. So the classification here represented tells you that the tumors can be classified as seminomatous tumors, non-seminomatous tumors, teratomas, and sex cord stromal tumors. The seminomas are further classified into seminomas or the typical or classical seminomas and the spermatocytic seminomas. Non-seminomas are classified into embryonal carcinoma, Yolk sac tumor, and choriocarcinoma. The sex cord stromal tumors include the Leydig cell tumors and the Sertoli cell tumors. Let us discuss about each of these tumors one by one. Like in any other organ, the germ cell tumor have also the precursor lesions. That means the in situ lesions from where the germ cell tumors arise. In testis, the in situ lesions or precursor lesions were previously called as intratubular germ cell neoplasia. I repeat, intratubular germ cell neoplasia. This has been renamed as germ cell neoplasia in situ. If you pay attention to the name, it will tell you about the features of this lesion. So this is a GCN, germ cell neoplasia. Okay, so it is a tumor arising from the germ cell, but it is in situ. IS refers to in situ. That means that the tumor is still confined within the basement membrane of the seminiferous tubule. As you can see in this picture, this is a seminiferous tubule and I have outlined the basement membrane. The tumor cells that you see here are all within the lumen and they are confined to the basement membrane. They have not invaded outside the basement membrane, hence the term in situ. So germ cell neoplasia in situ is the precursor for germ cell tumor of the testis. Well, please remember, not all testicular tumors will have a germ cell neoplasia in situ as precursor. That we'll see later. Sometimes it is important to identify presence of germ cell neoplasia in situ and they are confused with normal spermatogonia. So we use the markers by the test known as immunohistochemistry. The immunohistochemical markers for germ cell neoplasia in situ are enumerated here. They are three: the NANOG, OCT 3/4 and KIT. Please remember the names. These three markers are used as immunohistochemistry for detection of the germ cell neoplasia in situ of the testis. As you can see in this picture, this is one focus of germ cell neoplasia which has been marked by NANOG. The brown color in the nuclei of these tumor cells indicate that these are tumor cells. Normal cells will not take up the brown color, right? So this is about germ cell neoplasia in situ. So let us talk about seminomas. Seminomas are the most common germ cell neoplasms of the testes, and they usually occur within 15 to 35 years of age, not beyond that, and the usual presentation is a painless testicular mass. Sometimes these patients will present with disseminated metastasis. There will be lymphadenopathies everywhere, there will be masses. Patient can present with supraclavicular lymph node metastasis, and they won't tell you that there is a testicular mass. So please remember, if in a young patient in the 15 to 35 you are looking at a disseminated malignancy, do not forget to examine the testis. There may be a testicular mass hidden. Gross examination, as shown in this picture, the testicular tumor is usually well circumscribed. Mostly it has a solid cut surface. You may have areas of necrosis or hemorrhage. Sometimes seminomas occur with in combination with other types of tumors like embryonal carcinoma, teratomas. Then they can have a heterogeneous appearance. Hemorrhagic areas can be seen if they are combined with choriocarcinomas. So mixed germ cell tumors usually have a very heterogeneous hemorrhagic, necrotic appearance, whereas seminomas usually have a very homogeneous cut surface and which is solid. Microscopic examination. You might remember that when we were discussing the ovarian tumors and I was talking about dysgerminoma, I said that dysgerminoma is the homologous tumor of testes, that is seminoma and dysgerminoma are two similar kind of tumors. So here we call the tumor as seminoma, and in the ovary we call the same tumor as dysgerminoma, and we have discussed in detail the morphology of dysgerminoma there. To repeat, the seminoma morphological features are characterized by presence of nests of tumor cells. The tumor cells are usually present like this in nests, and they are separated from each other. The nests are separated by septae which contain blood vessels, hence they are known as thin fibrovascular septae, and these septae usually contain lymphocytes. As you can see here, the small dot like structures, they are all lymphocytes, because this tumor is highly immunogenic. So the immune cells or the lymphocytes tend to infiltrate throughout the tumor, and sometimes this immune response can lead to formation of granulomas within the tumor. So one seminoma is one example where you can see granulomas within the tumors. Other example being renal cell carcinomas and Hodgkin lymphoma. The tumor cells of seminoma are large and polygonal, as you see here. They have a centrally placed nucleus, and usually the cells have a very prominent nucleolus. The cytoplasm is clear because they contain a lot of glycogen. If you remember, this is very similar to the dysgerminoma of the ovary. So these 3 or 4 features, they characterized seminomas. You can get a question or short note on seminoma. Next common tumor in testis is a spermatocytic seminoma. Although the name seminoma and spermatocytic seminoma look similar, but the tumors are entirely different. We'll discuss about the differences between the two after this slide. If you see the gross picture, seminomas were well defined. Spermatocytic seminomas are also well defined. This is the cut surface of the testis. This is the normal testis and this is the tumor. Cut surface of this tumor shows you that it is very well circumscribed and typically it has a very soft and gelatinous appearance, unlike seminoma, which is firm in consistency. Microscopically it is characterized by three things, that is, it shows three different types of distinct cells: a large cell, an intermediate size cell, and a very small lymphocyte like cell. So there is a combination of large cell, intermediate size cell, and small lymphocyte like cells. This is very characteristic of spermatocytic seminoma and does not show you the typical lymphocytic infiltrate that you see in classical seminomas. This table tells you the differences between seminomas and spermatocytic seminoma. Seminomas usually occur in 15 to 35 years of age, as I have already mentioned, but spermatocytic seminomas usually occur in old person. The average age of presentation is 65 years. Seminomas, the precursor lesion is GCNIS, but spermatocytic seminomas do not have any precursor lesion. They are not associated with GCNIS. You see a abundant lymphocytic infiltration in seminomas. No such thing is noted in the spermatocytic seminoma. Neither it shows granulomas. Seminoma can occur outside the testes. Those are known as extragonadal seminomas. We'll discuss about that later on. But spermatocytic seminoma never occurs outside the testes. It's always confined to the testes. Seminoma can occur as pure form, can occur as mixed types. Mixed means mixed with other germ cell tumors like choriocarcinoma, teratoma. Then they are known as mixed germ cell tumors. But spermatocytic seminoma always occurs as a pure tumor. It is never seen as a part of mixed tumor. Seminoma grows rapidly. It's highly malignant, frequently metastasizes to different sites of the body. However, spermatocytic seminoma is a very slow growing tumor. It behaves like a benign tumor, does not show metastasis, and usually totally cured by local surgical excision only, whereas seminomas will require a lot of chemotherapy and radiotherapy. Talking about mixed germ cell tumors, in fact 60% of all germ cell tumors are mixed germ cell tumor rather than pure tumors. You can have a mixture of different types of germ cells, the most common mixture being presence of teratoma with embryonal carcinoma and yolk sac tumor. So three different tumors existing in the same lesion. The second most common combination is seminoma with embryonal carcinoma. And the third common combination is embryonal carcinoma with a teratoma. The combination of embryonal carcinoma and teratoma is known as a teratocarcinoma. From the treatment purpose, seminomas and the other germ cell tumor of the testes are treated in a different manner. So it is important to distinguish between a seminoma and other germ cell tumor. They are collectively known as non-seminomatous germ cell tumor. That will include teratomas, embryonal carcinomas, mixed germ cell tumors. If there is a mixed germ cell tumor and it contains seminoma, then still that will be known as a non-seminomatous germ cell tumor. So seminomas usually present at an early age, whereas non-seminomatous germ cell tumor has a late presentation. Seminomas, they usually metastasize via the lymphatics to the lymph nodes. So the common site to which they go is the retroperitoneal lymph node. Inguinal lymph node metastasis usually occurs when there is a tumor in the skin of the scrotum, but testicular tumors pass through the lymphatics and move to the retroperitoneal, para-aortic and mediastinal lymph nodes, through which they can go to supraclavicular lymph nodes. Whereas non-seminomatous germ cell tumors, they have early metastasis and they move through the hematogenous route. That means they can go to lungs, liver and other organs of the body. Seminoma is a relatively less aggressive tumor when you compare it with non-seminomatous germ cell tumors. So non-seminomatous GCTs are more aggressive. If seminoma is diagnosed, if it's a pure seminoma, then it can be cured with radio. It is radio sensitive, so radiation can cure 95% of these tumors, whereas these tumors are chemosensitive and its cure rate also reaches up to 100%. Now this is also kind of contradictory. Although this tumor is aggressive, but they are more chemosensitive. That happens because chemotherapy that we give to the patients, mostly they target rapidly dividing cells. So when a tumor is more aggressive, means many of the tumor cells are in the cell cycle and they are dividing, and chemotherapy is able to target those cells and kill them. So if a tumor is less aggressive and the number of mitosis and proliferation rate in the tumor is low, then chemotherapy is very less effective in such tumors. The issue of extragonadal germ cell tumor. Extragonadal means outside the gonad. So germ cell tumors can occur outside the gonads. Most commonly seminomas occur outside the gonads, but you can have teratomas and mixed germ cell tumors also occurring outside the gonad. You should distinguish between a metastatic germ cell tumor to sites other than the testes from a primary extragonadal germ cell tumor. We call it primary extragonadal germ cell tumor when there is no primary tumor in the testes. The only tumor that you see is somewhere outside the testis. Testis is normal. So if you look at this picture, many sites in the body can show you presence of germ cell tumor. The most common sites are the pineal gland region within the cranial cavity. You can have a mediastinal germ cell tumor. Germ cell tumor can be seen in the heart, in the peritoneum, and they can primarily occur in the retroperitoneum. Sometimes they are present in the lungs. So extragonadal germ cell tumor can present at various sites of the body. So this brings us to the end of our discussion on testicular germ cell tumor. Let me take you through it again. The germ cell tumor are the most common tumors of the testes. They are classified as seminomatous, non-seminomatous, teratomas and sex cord stromal tumors. Teratomas and Leydig cell, Sertoli cell tumors are very rare, and we have discussed about York sac tumor and in the ovary, so I didn't discuss it here. Embryonal carcinomas and choriocarcinomas are also extremely rare. Most of the tumors that you will see in the testes are seminomatous tumors, or they are mixed germ cell tumors. So we have discussed only those three things in our discussion. GCNIS stands for germ cell neoplasia in situ, and it is the precursor lesion for the germ cell tumor, mostly the seminomas. The marker for GCNIS are NANOG, OCT34 and KIT, and the test used to detect it is immunohistochemistry. Seminomas occur at a young age, present as painless testicular mass. They can present as occult testicular masses with disseminated metastasis. Grossly, it is well circumscribed and solid, and microscopically looks very similar to dysgerminoma, with nests of tumor cells separated by fibrovascular septae, and the septae are infiltrated by lymphocytes, and this is one tumor where you can see granulomas within the tumors. Spermatocytic seminomas are entirely different from the classical seminomas. Microscopically, they will contain three types of cells: the large cells, intermediate cells, and the lymphocyte-like cells. And grossly, peculiarly they have a very soft and gelatinous cut surface. The difference between seminoma and spermatocytic seminoma is of importance. Spermatocytic seminoma occurs in older age, is not associated with germ cell neoplasia in situ. There is no lymphocyte or granulomatous inflammation within the tumor. Unlike seminoma, it never occurs in extragonadal site and does not occur as a component of mixed germ cell tumor. It's slow growing and have a better prognosis than seminomas and never shows metastasis. Mixed germ cell tumors are very common. In fact, they are more common than seminomas, pure seminomas, and various types of combinations can occur. Most common being teratoma, embryonal carcinoma, and yolk sac tumor, and the combination of embryonal carcinoma with teratoma is known as teratocarcinoma. From a therapeutic point of view, the germ cell tumors can be classified as seminomas and non-seminomatous germ cell tumor. The treatment, chemoresponsiveness, radiosensitivity are different, although cure rates are similar. Seminomas can occur outside the gonad. They are known as extragonadal germ cell tumor. The common sites being pineal gland, mediastinum, heart, peritoneum, retroperitoneum, and lungs. That's all, folks. Thank you very much for listening.